So a very warm welcome to all the members of the audience to the webinar. It is the 9th webinar in the series under GAPIO Physiotherapy International Virtual Webinar Series. GAPIO is a non-profit organization established in 2011. Padma Vibhushan Dr. Pratap C. Reddy, Chairman of Apollo Hospitals Group, is the founder president of GAPIO with the vision improving healthcare worldwide. With the aim to bring together healthcare professionals of Indian origin globally on one platform through these webinars, our endeavor is to bring the expanded scope and latest advances in the field of physiotherapy to the fraternity globally. Today's webinar is on posture and musculoskeletal dynamics, physiotherapy perspective. We all as physiotherapists emphasize a lot on posture. Posture awareness is playing a big role in resolving discomfort, releasing tension, and alleviating pain. So for today's webinar, we have invited a group of intellects highlighting their perspective in posture awareness and variability through their areas of expertise along with its global scenario. We all know fascia is the largest sensory organ that permeates the entire body and plays a vital role in shape control and body motions. Structural integration creates a more effective use of the muscles, allows the body to conserve energy, and create more economical and refined pattern movements. So our endeavor is to share the knowledge through today's lined up sequence of 3 presentations from prominent champions in the domain. They will also shed light on the latest advances to help ignite a healthy discourse for clinicians and academicians in the Indian community for further enhancing their scope of practice and patient care. I would like to make an announcement. All of you, please put your questions in the chat box, which will be taken up in the end. So to introduce our first speaker, Dr. Derek Gill. He's founder of Global Structural Integration.org, owns Advanced Manual Therapeutics, Hawaii, United States. He's faculty member at Pacific Center of Awareness and Bodyworks, and emphasizing somatic neuroscience, mindfulness, and practitioner cultivation. Kindly put yourself on mute. He has studied from Osteopathic College of Ontario. He is diplomat in osteopathy and also a certified advanced rolfing trainer. So he was kind enough to share his recorded message with us to set the ball rolling for us to really understand the theme on which we have our webinar today. So over for Derek's presentation.
शेयर कर दिया क्लिक करो जूम उसको क्लिक किया आपने शेयर को हाँ इस पे वीडियो पे क्लिक करो शेयर साउंड शेयर कर ना साउंड नाउ
Namaste, everyone. My name is Derek Gill. I'm the founder of Global SI School of Structural Integration. First, I'd like to thank Dr. Grover for her kind invitation to speak to you all at this webinar. I apologize that I can't make it in person. I'm actually teaching in Chennai this week and need to make sure I'm fully rested for the live classes that are going on. I would like to offer what I hope will be an interesting perspective regarding the topic of movement dysfunction and musculoskeletal considerations. I think you're probably going to get a lot of information from some great speakers about the biomechanical view of this, and that is a great lens to look through. There are certainly, just from a gravity and physics point of view, probably more optimum joint positions, more optimum movements that over time would influence how a joint's gonna age, how wear and tear will affect it. I would also like to add in a couple of structural integration concepts to hopefully broaden your field of awareness when you're working with people. Oftentimes, if we begin to speak to people in terms of these biomechanical dysfunctions, even using the word dysfunction can actually alter their perception, and we can have some unintended negative consequences. So it's really important that the words that we choose when we're talking to people, and that we can help them look for their health and not their dysfunction, because people can hear these words and begin to identify with them, feel broken. This increases the chance for a threat perception to happen in the brain, and pain output signals to happen. It's tricky though, because this is how we learn, right? We break things down into small details. We name individual muscles and joints and bones and ligaments and tendons so that we can have a conversation, which is necessary in order to learn. But it's important that when we're interacting with the human being in front of us, that's our patient, that we kind of shift gears, that we're not talking to our colleagues, but we're talking to someone who is hanging on our every word, because most people, by the time they come to see us, they have endured some discomfort, dis-ease in their life. The one thing I want to share is a structural integration principle called palintonicity, P-A-L-I-N-T-O-N-I-C-I-T-Y, palintonicity. And this speaks to balanced tension in multiple directions. So normally, most of our anatomy, especially when we're talking about biomechanics, tends to be longitudinal. We're talking about the lever and pulley system of muscles acting on bones, which cause joints to move. What if we were to broaden our mindset and our lens of perception for a second, and think about the whole body, and think about, can we help the person find an internal sense that lets them feel expansion in multiple directions? Maybe one of the easier places to think about this is the diaphragm, the respiratory diaphragm. Can the person get lateral expansion when they inhale? Can they breathe into their back? Can they breathe into their front? Can they breathe above and below? Most people have not had this experience. They've never been asked to do it. They've never thought about it. So even this small perceptual inquiry that you offer them can make shifts in their musculoskeletal system, because ultimately the muscles are the workers, right? And when we give the person new concepts and new perception of how their body works, we begin to talk to the boss, right? And it's the brain that is determining resting tonus of structures. And it's the brain that decides what's safe. And when we think about posture, it's not just about shoving someone into what we think is the right position, even though biomechanically we can anticipate like the load and the wear and tear is less in the joints. In order to make lasting change, we have to get the person to make meaning of what their body is doing, make meaning of their posture, and understand how they can shift this for themselves. And we're there to help. We're there to give them expertise. We're there to encourage them, but ultimately they have to take ownership of the work, or it doesn't last. I'm sure many of you have done some incredible treatments, and there's a certain population of the patients that come back and report everything's still great, and there's a certain population that comes back and says, hey, I felt great for a day or two and then it came right back. So how do we approach this? And that's why I want to offer you some concepts that might be new to you. So posture can be related to safety. Like, how do I feel in a certain posture? Now we begin to delve into the psychological as well. If I'm feeling overwhelmed and downtrodden, might that show up in a bit of flexion? Might that show up if I'm stressed? Might that show up in my shoulders? So, we can give them strengthening exercises to change things. We can do manual therapy to, help relax things. But if we don't give them the bigger picture of you know, how can we give them tools to begin to inquire about their state? This is a huge gift if we are patient and willing to learn those skills ourselves. And I'm talking about interoceptive skills. Can we give them a felt sense vocabulary so that they could begin to explore what they feel when they experience their body? And when we are able to give them a window of change through our manual therapy, through our strengthening exercises, and they feel different, if we can anchor that window of change as a possibility for them and get them to take ownership of moving into that as a more permanent way of being and organizing themselves in the field of gravity, now we're making lasting change, and we are shifting the perceptual fields with the boss, not just pressing on and stimulating the workers. I hope this has given you something to think about, and I hope it stimulates your curiosity and you go and Google away. And if you've got some colleagues that have done the structural integration training, you might reach out to them and ask them how this kind of thinking has changed their patient outcomes. Again, thank you so much for the opportunity to speak at this webinar, and I wish you a great rest of the webinar with the other esteemed speakers. Namaste.
Seema ma'am, you are on mute.
Yeah.
Yeah.
We thank Dr. Derek to even give the recorded message to set the ball rolling. At least we know that which concept, and what beautifully he has put it, kind of patient's perception. So many times we work as practitioner, but what a patient should also introspective skills by the patient. So without taking any further, now I would introduce our next speaker, Dr. Marius. He's kind enough to accept the invitation on very short notice. So he's a physiotherapist and structural integration teacher for anatomy trains for nearly 2 decades. He has been cooperating with such specialists in the field as Robert Gill, Tom Myers. Many of us would have heard those names. So now through him, we'll have a reflection of these guys whom we have just read or heard in books. But yes, he is with us to share his knowledge. He also owns a Polish publishing company, S3 Publishing, and he specializes in anatomy and bodywork related books. So over to you, Dr. Marius. We are all eager to hear you because 30 minutes is very short for all the concept what he's going to give us.
Thank you, Dr. Seema. Thank you for inviting me. It's my pleasure. I'm very glad to be here and share that virtual space with you. It is very difficult to show something in half an hour, but I'll try to summarize the best I can what anatomy trains represents and what we're trying to show and teach other people, right? So that will be also in relation to posture. I'm sure most of you have heard about anatomy trains. So maybe what I will say, it will clarify or maybe put the order to the knowledge that you already have. And for people maybe who are not familiar with anatomy trains, that could be like the first introduction. So again, thank you for inviting me. I hope you can all hear me well and see me. I will share my screen now. Okay, just a moment. Got it. All right. Can everyone see?
Yes, we can see. Sure.
All right. So again, thank you for having me here. I will try to show you the different, slightly different biomechanical perspective that anatomy trains proposes for a manual therapist and for a physiotherapist. So anatomy trains, it's a school based in America, and we are also having the branches in Europe, in UK. I'm based in Poland, but we teach worldwide, and our program is concentrated on either modular or intensive formats. So either you fulfill those weekends workshops, or you go for intensive format where you study in America directly with Tom Myers. That's a little bit more intense and takes a little bit more of a time at once, right? And our school goal is to teach people how to restore postural balance, how to improve the movement function, how to ease those fascial restrictions, and promote the body awareness. What Derek was saying, that patients have to own the changes that we're proposing to them. We can work on someone's muscles, but they have to own it. So they have to be aware of those changes. They have to receive them and own them, right? So structural integration, this is also process of teaching the person how to experience that body, their body, and how to experience the progression of sessions according to original or new recipe of structural integration. And I will talk about it a little bit more. So anatomy trains structural integration. Anatomy trains, it's a global map of human structure and the movement. There are lines that represents force transmission, and this is the myofascial system in our body. So this is the longitudinal anatomy. I'm sure there is a lot more to human structure than only longitudinal connections, but this is the first ones and the strongest ones that will be influencing our pattern, our postural pattern in space, how we stand, how we move, right? So I know everything in the body is connected, but some things are more connected than the others. And that does myofascial continuities that we call them anatomy trains lines. But it's not only anatomy trains, and it's not only Tom Myers that noticed them. So what the anatomy trains isn't, right? We're not exclusive. We're not claiming we only write. We invite into a conversation all other professionals, and we eager and keen to learn from everyone, right? We all searching for best answers, right? And we don't have answers for everything. Anatomy trains, it's a map. It's a good map how to see body, how to a little bit simplify it so you can understand what your strategy for that person is. And this way, it's easier for you as a therapist to move along with a clear signal of progression of your session. So what Derek was saying, that the client need to receive and understand what we're offering as an opportunity for a change, right? So as a structural integrator, you're offering that progress, that experience of it, right? So we do not have answers for everything, but we also looking, right? We're inviting everyone to conversation, and we're looking out for best answers for that client. Yeah. So we all here possibly because you know some of those titles, and I guess some of you have read the Anatomy Trains books, so you are familiar with the basic concepts that Tom Myers show in that book. I could suggest other books on that subject, and you can see them next to Tom Myers' book. So our history as anatomy trains, this is coming all the way from Andrew Taylor Still and Alexander and Moshe Feldenkrais through Ida Rolf that Tom Myers studied directly with, right? So Ida Rolf, she was the creator of something that it's called Rolfing nowadays, and structural integration in broader and wider term. So Ida Rolf said that something can be done about anything. Well, sure, at least we can try, right? So Tom Myers, he was studying with Ida Rolf, with Moshe Feldenkrais, and also with Buckminster Fuller. And he put together Dr. Rolf's vision of fascial connectivity into the whole body approach that was maybe specific in a tensegrity view of a body that Buckminster Fuller invented, right? Looking at the body in more connected way. So Tom Myers put that vision together, and that's how Anatomy Trains came about, right? So what is the structural integration? Because I said, Rolfing, sometimes it's called structural integration. Structural integration, it's a wider, bigger term for type of manual bodywork. Anatomy Trains, it's one of the schools of that type of bodywork. The common thing for our schools is that we follow, sometimes close, sometimes not so close, to the original recipe of Dr. Rolf. And the recipe, this is the order of a progression of 10 or 12 sessions when you do a manual therapy with the person progressing usually from the superficial to deep. You take them from releasing the sleeve towards more of the core problems, right? So through that protocol, we're keeping order and we're keeping clear message towards the client so they can own that message that we're trying to give them. We're trying to give them the opportunity for a change so they can keep that change, yeah? So that protocol gives us the goals and a structure of work progress during the series, but also gives you a freedom to adjust what you're doing in accordance to what specific client needs. So it's a frame, but it's not tight frame. It's not the tight prescription what you do, because you're adjusting that for every different client for what their possibilities, what their needs are. Yeah. So how that relates to posture? Of course, posture and gravity matters, right? As Derek said, it's not only that, right? Our posture reflects more than just the gravity and not just the biomechanics, but this is the beginning, right? Before we can talk to someone on the level of understanding and feeling the body, the equal expansion from the core, very often we have those adhesions and we have those restrictions, those limitations that clearly coming from the superficial layers. And that will be our first call. And this is also the first things that you do in a structural integration. You take care of the superficial issues before into go deeper stuff, right? Before person can start owning the changes in their body by understanding and feeling them, right? So sometimes there is no escape. There is the simple biomechanics and there are the muscles, right, that we're dealing with. And posture and gravity, it matters because we all live in a gravity. We all need to adjust somehow to it. And with time, that posture becomes ingrained in us, and the fascia as the medium that holds us in space, it reflects what's happening with us over time. So we will have the densifications, we will have that effect on the changing of our posture, and then we are fighting against our biomechanics and our limitations, right? In general, what's causing the body to misalign? It's the immobility, dehydration, and inflammation. That will be causing stiffness in the perifascial tissues, in those tissues that are surrounding other tissues, and that will be creating a lack of mobility. And lack of mobility will be creating compensational patterns, and that will be creating overall postural pattern of someone, right? And there are so many factors that could be working towards that. So our posture, it's a reflection of very complicated matters, right? So of course, even if it's the emotional representation of our state, our posture, it still will have an effect of what's happening inside our body, inside our frame of our bones, right? So any limitations, emotional or not, in our posture will be reflected in our movement abilities down to each joint, right? And with time, our fascial system, our body, trying to gain equal tension, will be adjusting to those changes in patterns of our movement and posture, and it will be creating densifications to support those patterns. So our posture becomes more and more ingrained in us. And we see and we feel that in us, yeah? So as a structural therapist, we're almost trying to turn back time, right? We're trying to reverse a little bit of that effect that time will have on us with the gravity, right? With everyone have some sorts of attitude, some sorts of relation to gravity. And as a structural therapist, we're trying to make it better. We're trying to make it more aligned. Yeah. So medium to that, it's fascia. And it's been in discussion what the fascia is. And what you see on your screen, this is the latest definition of the fascia and the fascial system, right? So wherever you can cut out with knife during the dissection, it can be cut out. This is the fascia, right? So any sheet, any number of the other dissectable aggregation of connective tissue that form beneath the skin, that's the fascial tissue. Fascial system, it's the network of that. That's actually, this is a more functional name of it. Fascial system already reflects that there is a function to it, right? And the fascia function is actually to create our shape and to give us the function and to give us the movement, right? So this is more like a biomechanical auto-regulatory system. So it's our organ of form. It's a single continuous interconnected web. It's a strain distribution system that communicates throughout the body, has viscous and elastic properties, and it accommodates and holds the patterns and compensation. That's where our posture is held, right? In the fascia, not even so much in the muscles, because the muscles, they like engines that move our body, right? But our posture, it will be held and restricted more in the fascia itself, or in the lack of movement in the fascial tissues that will be restricting the motion of and the action of muscles, right? So fascia can have different forms. All of those things that you see on a picture, this is the fascial tissues. And this is Dr. Jean-Claude Guimberteau, French surgeon. He was one of the first persons that recorded live fascia in a live body. During the surgeries he was performing on a hand, because he is a hand surgeon, he was sticking a camera under his skin, and he noticed those tissues in a live body, right? And I'll show you some clip right now. So please look at that and look at the fibers and look how shiny that tissue is. This is the perifascial tissues. This is the fibers of something that you can see with magnification of maybe 25 times. So it's not a huge microscope. Actually, kids' microscope, you know, the one you have as a toy, can pick up those fibers, right? So you can see that this is very, very hydrated. This looks like layers. This looks like trapped fluid. This looks like trapped fluid that forms in fibers. And you can see that this fluid sometimes travels up or down, so the gravity doesn't really matter. And you can see that there are layers to it, right? If you're familiar with Gill, a famous anatomist in America, a long time ago, he was having a famous internet fast speech. In that fast speech, he was calling those tissues as a fast, because when the person or when the cadaver dries out, that becomes drier and drier, and it starts looking more and more like a fuzz, like a cotton candy. Yeah, it becomes more like a cotton. But when a cadaver is fresh, or when the person is alive, actually this is more as membranes, as watery membranes. And Gill lately, he had a tour through United States when he visited hundreds of cities, and he was showing those tissues, saying that those are perifascial tissues, loose areolar tissues, that in a live body, they are actually very watery. It only when the body becomes dried through immobility, through inflammation, that becomes more and more sticky, and then it starts resembling the fuzz, the cotton candy, and that starts restricting our movement, the movement that should be the shearing movement that should be in between the layers. Yeah, because the movement in the body actually happens through the layers of those membranes that you're looking at, those watery membranes with those fibers. So any restriction in that, any lack of that hydration, it will be also restricting movement of the bigger structures, and lack of movement in those structures will be our posture, basically. So what cells do we have in the fascia? We have the fibroblast, we have the myofibroblast, we have the fasciocytes, and we have the telocytes. All of them, they create that network, right? And all of them, they are living in that extracellular matrix. The ground substance and all of that, we have all the cells of our body embedded in it. Yeah. So Jean-Claude Guimberteau, he was calling those spaces in between those fibers microvacuoles. And in those microvacuoles, he said that the cells are actually living embedded in it, like in a hammock. Yeah. So our body is created with the extracellular matrix. And in that extracellular matrix, we have cells, specialized cells that are embedded in it. So also in fascia, we have our sensory organs, our mechanoreceptors. And those mechanoreceptors in the fascia, they will be responsible for feeling what's happening in terms of mechanical influence to the whole system, to the fascia and to the tension through maybe specific paths that going through our body. Yeah. So we have that in our body, and here you can see the myofibroblast that's been recorded, and this is the recording over 75 minutes. Let's play it again. So that short clip, this is the 75 minutes of the myofibroblast creating denser and denser matrix. You can see that it looks like a slug, maybe like a spider that creates thicker and thicker spider web behind it. And the myofibroblasts, they will be responding to a piezoelectric charge, and they will be creating that web. And the piezoelectric charge will be happening in our body in accordance to our mechanical demands. And what happens if we don't have the mechanical demands, if we don't exercise, if we don't move, if we don't keep our body active, we're losing the regular lattice of the fibers of that fascia, and our fascia becomes like a felt, becomes denser, and the fibers are not regularly oriented, and also they losing the crimp. They're not elastic anymore, right? That's losing elasticity. So sedentary lifestyle, not exercising, it's us losing the elasticity in the fascia that covers our muscles. Yeah. So we all kind of familiar with the musculoskeletal system and those terminology, but if we omit fascia, then we're missing something. We're missing the system that connects the muscles and bones. Well, this is fascia. And we're missing the north and south connections. That will be, let's say, anatomy trains or slings or something that Andrew Fleming was saying in the 80s. And also we're losing east and west connection. So side to side neighboring tissues through the areole transmission of forces, through those watery perifascia, as Gill calls it, they will be transmitting the tension from structure to structure, but neighbor to neighbor, not in one after another chain, but next to each other, right? So then also we have something that it's called the dynaments. So this is another muscular connection to ligaments, yeah? And also, if we don't include fascia, we're losing a neurovascular connection. So something that visceral medicine talks about, like Barral Institute, yeah? So here you have a look at the thigh, and in this thigh, you can see that all the muscle cells, they have been removed. Here you can see pretty much the deep fascia and all of its connections to the bones. So you can see that although the muscles are connecting us through the organs and insertions through the bones, but actually stronger connection, I think, stronger thinking from the perspective of posture, it's coming from the deep fascia, because it's actually deep fascia that connects the outside sleeve of the motor units as the muscles to the bones. And if we have any limitations, any restrictions, or any adaptations, thickening through so many factors in that structure, that will be holding our postural patterns, right? Muscles are soft, they are powerhouses. The patterns will be held in the deep fascia. So here again, we have layering of the body. So we'll be having the skin, superficial fascia, deep fascia to the bone. And through all of those layers, those limitations can occur. All of those layers can adhere, can be stuck, can be immobile, and that will be changing the pattern, and enough that you will have a one change somewhere, and then the body will try to compensate for that, and that will be building up higher and higher our pattern in response to the initial change. So posture, biomechanics, movement, and then movement efficiency, this is all connected, and somehow this is all comes down to fascia that creates our body. Yeah. Here I have a little bit of a really cool clip of the superficial fascia glide on top of the deep fascia. This clip comes from Gill. Yeah. Please have a look. So superficial fascia, it's basically all the subcutaneous fat. Some books, they specify the superficial fascia as a specific thin layer in between the subcutaneous fat, but basically it's all the framework that subcutaneous fat is embedded in. So everything that lies on top, deep fascia. So you could see that there was loads of movement there, and any restrictions in that, they will be reflecting in what's happening deeper down in the body. So even the restrictions in a superficial fascia glide, that will be reflecting deep down to a deep fascia, and that will be reflected in our postural pattern down to the spine. And again, you can see the movement.
Sorry to interrupt you, Marius. We cannot see
Yes.
your screen at the moment. Yeah. Your screen
Yes.
sharing has stopped. Yeah.
Okay. Can you see it now?
Yes.
Okay.
No.
Okay. Everything good?
Yeah.
All right. So you can see that the superficial fascia, the skin, and all of that, even just those first initial tissues that usually we overlook, that could be creating the first factor in our postural pattern. And then the next layer, the layer that anatomy trains and most myofascial therapy focus at, you can see on the screen that this is the deep fascia that covers our muscles, right? Before it interacts with the epimysium. So you can see the deep fascia, it will be that leotard that covers our body. And then the next layer will be having the epimysium. Here you see on that video, you will see the deep fascia that have a Windows cut, and you will see the movement of epimysium under. And again, this video comes from Gill. So under, you can see the epimysium of a muscle moving under cut windows of a deep fascia. In between them, there have to be the layers of the perifascia, that fuzzy stuff, that cotton candy, that have to be full of water to allow that gliding movement. If it becomes dried out, it becomes like cotton candy, then that's already becomes a restriction. Any bruising, any hematoma, any inflammation, that's already influencing that glide. Yeah. Here, what you're looking at, this is the hamstrings, and this is the hamstrings gliding in response to plantar and dorsiflexion of a foot. You can see that dorsi and plantar flexion of a foot having a great effect on the hamstrings, and you can see how complex that movement have to be all the way up to the thigh. So any lack of movement in the foot also will be restricting the motion higher up. It's all connected, right? So I'm sure you're all familiar with that, with layers of the myofascia, yeah? And you've been looking at right now on the epimysium, right? And through the connections with bones, all of those fascial tissues, they will be part of our postural patterns, yeah? And right now, what anatomy trains offers is a changing of theory coming from individual muscle theory to myofascial continuities. And I know we're using the muscles to describe the lines, but we're not only meaning the muscles, we're meaning everything that surrounds them. So we're meaning the epimysium, and we're meaning all the perifascial tissues that surrounding those chains of myofascial force transmissions. And so anatomy trains, although it's described in a chains as a connections through from one muscle to another, we more mean the surrounding tissues. It just, we need to communicate that somehow. Yeah. So we have those connections in series. So force transmission will be going in series along the anatomy trains lines, but also in parallel. And in parallel, that will be force distribution system through side to side, touching the wall, neighbor to neighbor. Yeah. And back in 2009, in a paper published by Franklin Miller, it was described that the strain transmission during the flexion of a hip. And you can see on that slide that during the hip flexion test, there was a certain amount of force transmission through the neighboring structures. And actually, all of that transmission of forces reflects perfectly way of lines of anatomy trains. You can see that this simple movement on a cadaver created the transmission of the forces farther up the chain in the body. Yeah. So that's where we have the anatomy trains lines. And anatomy trains lines will have the first mostly superficial lines that's surrounding our body: superficial front, back, lateral, and spiral line. Superficial back line, well, if you cut everything out from the back, that is not vertical, this is your superficial back line. And posturally, it goes from the toes to nose. It contains higher proportion of slow twitch muscle fibers. It lifts us up and it holds us up and it keeps us from falling, right? And it is strongly connected with our vision and keeping our head with the line of the horizon. Then the next line, it will be the superficial front line. Again, if we remove everything from the body, from the front of it, that it's not vertical, we're left with the superficial front line. And this line, posturally, it's more involved with covering our soft and vulnerable parts. It's more emotionally charged. And this line, it's more connected with flexion, right? The next line, it will be the lateral line. And we have both of them. So we have the front, back, and then both on the sides. This is the lateral lines. Lateral lines, they connect front and the back of the body, then balance us right and the left, and they becoming the adjustable breaker for our pelvis motion side to side. Then the last superficial line, it will be the spiral line. So you can imagine this one goes spiraling through the body. We have two of them, and they will be connecting all other lines. So we can see that in this way, the way it goes, it will be influencing our posture the most, right? So sometimes people will ask which line influences the posture the most. Definitely the spiral line will have the most potential to create postural pattern out of the neutral. Yeah. So we have the superficial lines that are surrounding our deep front line. And our deep front line, this is the line that we see that best as a volume, because it's a volume like a core inside our body, and it's surrounded by the superficial lines that creating frame for that deep line to expand and express itself. As Derek said before me, we're trying to teach people how to expand equally from the inside, how to feel that. But sometimes the superficial tissues are still restricting. And that's why you need a little bit of myofascial release to help them out from those clearly mechanical restrictions, right? Before you move on towards more experiential stuff, right? So the deep front line lifts the inner arch, stabilizes the legs, supports the lumbar spine from the front, stabilizes the chest while allowing expansion and relaxation for breathing. This is very important, very difficult part, right? It balances the neck and the head, and it has the relationship with any other lines, right? So here, again, coming to the end in that short half an hour, the deep front line, I have a difficult task of holding our core stable, but at the same time allowing the movement in it. That's very difficult to achieve, right? To provide the stability and allow mobility just enough and just right portion, right? So I have a really cool clip here I would like you to see. This is the internal organs. Diaphragm is not there. You can see how much motion there needs to be happening just in response for breathing. This is your lungs being inflated, and you can see true gliding motion through the fluid. It's only in our viscera that our viscera glides on each other through the fluid interface. Everywhere else in our body, we're gliding through the perifascia, through that cotton candy. So there is a lot of potential of that cotton candy being a little bit too dense and start restricting that motion, right? So that leads us to a question: what about us as a therapist? What we can do about it, right? Here we have the deep front line, we have the surrounding superficial lines that very likely will be part of any postural pattern. Is there anything that can be done, right? Because you can see right now that all the superficial lines, especially the spiral lines, this is creating the spiraling rotating motion through our body in our most basic function that we do, which is walking, right? When we walk, we have the lower part of our body rotating to one side, when the upper part of our body rotating to the other side. And power for that, it comes from our superficial tissues. Imagine the obliques, right? It's the obliques that creating the power and the potential for that motion. When we walking in rhythmic, uninterrupted way, then those are our friends. But if there are any inhibitions, if there are any tensions, if there are any restrictions in, let's say, thoracolumbar fascia, that already creates different bony mechanics inside our lumbars, and then something that Serge Grakowiecki called as a spinal engine is not in the best mechanical position to be using that elasticity that is given to us from those oblique tissues that surrounding our abdomen, right? So does any postural pattern reflects in motion onto our spine? I will say yes. Even the smallest postural pattern will have either preference for the right or left rotation of the thorax in relation to the pelvis. And if we have that, that's already creating our pattern. And that's already creating some sorts of preference that maybe with time, if it becomes more and more exaggerated, might not work towards our benefit. All right. So this is our thoracolumbar fascia. And can we make a difference? Structural integration is trying to influence the soft tissue and influence the tensions, adhesions, and any restrictions, and provide the experience for the client going through the progression of those sessions, experiencing from the sleeve towards the core, how their body, it becomes more and more freer with each session that we giving them. That's what we aiming, right? This is our goal. But of course, we have those first obstacles, and sometimes some clients, they just present loads of work that's clearly mechanical and clearly myofascial, right? So every client, it's a different challenge, right? So now, as anatomy trained structure integration, we do teach you how to do body reading, because in my personal opinion, first you need to be able to see the general pattern. And then when you see it, then you can start think of what your goals. And when you have your goals, that gives you a strategy. And then when you have your goals and your strategy, that leads you to manual techniques. There is no need to be learning the manual techniques and repeating all of them, hoping that one magic one will catch something and something will change. It's not difficult actually to create a change in the body. The difficult is to create the change that you want and keep progressing in the direction that you want. That's difficult, right? So as anatomy trains, as a school of structural integration, we do teach you those skills the best we can, and we do try our best to convey that knowledge to you. So I hope to see you sometime this year. Next year, we will be teaching in New Delhi and in Mumbai. Thank you all. Thank you, Dr. Seema, for inviting me. It is difficult to fit that broad subject and territory in half an hour. I think I'm already late. Thank you so much.
Thank you,
I
Dr.
stop screen
I
sharing.
believe
Thank
you
you.
have justified 30 minutes and everybody would have really enjoyed. Without wasting much time, now I would like to invite our next speaker, Dr. Neha Khera, on the role of major 5 in posture. Since today we are talking about posture, I thought it is a pleasure to have you, Dr. Neha, here. She's Director of Physio and Fitness, founder and instructor of Let's Diagnose and Tape. She is level 10 graduate in structural integration from Florida, US. She's level 3 certified in neurokinetic therapy, California, USA. She's expert at gait analysis, body readings, and breathing patterns. Advanced TMJ expert, pelvic floor treatment specialist, and level 4 expert in applied physiology. So we have another very, very knowledgeable speaker to us. Without wasting any long, she has a huge line. She's EC member to Delhi IIP. She's treasurer to National Association of Structural Integrations and various awards to her kitty. Now, without wasting any long, I would like Dr. Neha to please start with your presentation. Let's all really hear you.
Hi, everyone. I hope I am audible.
Yes.
Yeah, so today I will be discussing the role of major 5 muscles which are involved in our posture. So first, just a brief about what is posture. Posture is an attitude we assume. It is either with support to the muscular activity or coordination of many muscles. Okay, so it is something which is adapted continuously. While you're sitting, standing, you keep adapting to the postural changes. So what is involved in a posture? So a muscle is involved, a joint is involved, a perception is involved, which is very important, and then an emotion is involved. I will be discussing about everything in detail. Next. So what are the major 5 we are talking about today? First is, we have heard these names many times. The first is multifidi, then is quadratus lumborum, then is psoas, then is rectus abdominis, and the transverse abdominis. Okay. And next, why have we taken these 5 muscles? These 5 muscles basically form the core jacket of our body. It maintains the intra-abdominal pressure. So intra-abdominal pressure and the posture are directly correlated. A good posture can never be achieved without a good amount of intra-abdominal pressure. So intra-abdominal pressure helps, and these muscles help us to modulate the volume of the thoraco, the abdominal, and the pelvic cavity. So what is it is useful for? It is useful for so many things. It is useful for breathing. It is useful for anti-gravity postural control, coughing, nose blowing, birthing, continence activity, especially during running, jumping, vocalizing, sneezing, and other things. So basically, what is intra-abdominal pressure? A very brief view. It's a steady state pressure concealed within the abdominal cavity, which is measured. Normal is 5. In critically ill patient, it comes down from 5 to 7 milligram of Hg. And obese, it comes to be 15 milligram of mm of Hg. So what muscles are responsible for maintaining them? Basically, are transverse, abdominis, diaphragm, pelvic floor, and the lumbar multifidi. So now these are the functions of the intra-abdominal pressure we have already discussed. So most importantly, intra-abdominal pressure provides the internal stabilization to the spine, especially with the action of psoas. So, so there's a triad in this, you know, the diaphragm comes above, pelvic floor comes below, and then comes the transverse abdominal. There's a tonic and a phasic activity. These muscles helps to maintain the tone and the phase. Okay. So the superficial, we have a layer of extrinsic and intrinsic muscles, which I will be telling further. So what is basically tonic? It is just to maintain the posture upright, maintain the tone of the body so that the posture is maintained upright. And the phasic is to meet the prevailing demands of respiration. Phase happens in different phase. In the phase of respiration, we have inspiration, we hold the respiration, and then we expire. So these muscles are responsible for phasic activities and postural reflexes and the movement of the trunk, small, big, whatever is as required. So basically now we'll be talking about intrinsic and extrinsic core. First, it was Ida Rolf who gave us this concept of what is intrinsic and what is extrinsic core. So intrinsic core is basically the core, the inner being, the inner muscles. And it is our inside, you know, being ourself, being us. The extrinsic core are the sleeve. They are the superficial muscles. So now Ida Rolf was the first person who found out that when there is a disturbance in these muscles, one takes over the other. It's usually the extrinsic core muscles which come into substitution when the intrinsic core muscles are affected. So this is the differentiation. Intrinsic core muscles, they provide us the segmental stabilization of the spine. And they work at each segment of the spine, you know, at each level, one by one. So these are the two basic muscles, which is one is multifidi and the other is transverse abdominis. Whereas the muscles which create gross movement, you know, and provide the gross stability are the quadratus lumborum. And there are other muscles which are involved besides these two, as intrinsic core are obliques, our diaphragms, the pelvic floor, and the lumbar portions of the longissimus iliocostalis, which we famously know as the erector spinae group. Okay. And the other muscles which are as a part of extrinsic core are external oblique, internal oblique, erector spinae, lats dorsi, glutea, adductor, and hamstrings. You know, what is the key point to note here is that it is always the extrinsic core which gets involved when the intrinsic core is affected. Okay, so they take over the role of all the intrinsic core muscles. So initially, if someone comes to our clinic, you know, the first session, we are taking care of the extrinsic core, you know, not directly going on to the intrinsic core muscles, because those muscles are protecting you. They are keeping you in a protective posture to further decrease the damage or cause harm to any other part of the body or even to the organs. So in initial sessions, we take care of the extrinsic core and then we jump onto the intrinsic core muscles. Okay, so what muscles are active and inactive out of these major five during the posture? I'm talking in the terms of a standing posture, you know, a neutral, when we are standing in a neutral position, in an anatomy position, you know. So the active muscles are psoas and multifidi. Why are they called active? Because they are usually working against the gravity, you know. They are the anti-gravity muscles which maintain our posture. They are continuously working whenever we have an active posture, like even in active standing. And inactive muscles are the quadratus lumborum, transverse abdominis, and the rectus abdominis. So now I will be talking in respect to each of these five muscles and what are their effect in postures. So when we have an psoas, which is overworking, you know, or it is short. So what happens to the neck? I'll just stand up for a demonstration also. So when we have a short psoas, what will happen? So this is the posture which we will be getting into. So what happens to the neck? The upper part of the neck will get flexed. Okay. The lower part of the neck will get extended. You know, we will be like this. And back, there will be an anterior tilt. Okay. Knees could be neutral or hyperextended depending on how long a person has been in a particular position. And then when it comes on to ankle, it will be plantar fixed. You know, what happens to the neck will happen at the ankle. You know, it's always simultaneous. And when we have a weak psoas, we will get a sway back posture. It will be this way. So it's the opposite here. The upper part of the neck will be extended. The lower part will be flexed. and we'll have a flat back. This rounded curve, which we attain, which is a secondary curve, which we attain when a child starts walking, will get flattened, and knees can be neutral or they'll go flexed, okay? And the ankles will go into dorsiflexion. So this is the effect of psoas. Now we'll discuss the effect of rectus and the transverse abdominis. When there is an imbalance between the rectus and the transverse abdominis, usually, transverse and rectus, transverse abdominis is a deep part of a deep fascia, These are a part of our intrinsic core, while rectus comes to be a part of extrinsic core, but they often function simultaneously depending on what posture we are there. So the transverse abdominis activates and advances of the rectus abdominis and is more tonically yet adaptively involved in generation. As soon as our body gets a reflex of any kind of action, the action could be a bilateral limb action, lower limb, upper limbs. First, we have many times in many research works note the change that the first change happens in the transverse abdominis, and then we are able to take care of all the limbs which act. And rectus abdominis comes later. So this is where the fault lies when a gymmer trains, when a person who has a less knowledge, they keep on doing those crunches and all these activity in which only the rectus is recruited. This leads to disc herniation in people who do a lot of exercises, a lot of weight training. So we here have to make sure that the transverse abdominis is trained first before the rectus abdominis. In that, the best exercise is that you should go for a gym ball exercise, you have to recruit a transverse abdominis more than the angle it is involved. When we do a gym ball exercise, it's a transverse abdominis which is recruited prior to the rectus abdominis. So then if we have a tight or a overactive abs reciprocally, both the end of the sternum and this pubic, this will come close, They will come close. Then again, we have a sway back posture. We'll be having tight abs, okay? And our thoracic range motion, making it more difficult to sit or stand when we have an erect posture for a long period. Next, we'll be discussing the role of multifidi. Multifidi and abs are the ones which will work in a cohesion, because these abs, when they go backwards, we have always also seen in anatomy, the transverse abdominis is seen here also, which is now then attached to the lumbar fascia. So multifida and QL are the continuation of this transverse abdominis, okay? So when we have a weak glute, which makes the erectors and the multifida to overfire, as we have shown in the figure which is on the right side, when we have a weak glute, our erectors and the multifida, they overfire, which results in lordosis. You can very well see these markings on a person. They'll be having a very tight fascia, and tight fascia could be, as Marius told, because of decreased like activity and decreased hydration. So a lot of role in multifidi of hydration is very important. The spine, the interspinal disc is 95% water. So as soon as we ask the client to drink a lot of water and do exercises, everything can be fixed. And when we are talking in terms of a weak multifidi, the abs, they overfire, The multifidi weaks, the abs overfire, and we come into a sway back posture. Next, we talk in terms of QL, quadratus lumborum and psoas, they always go hand in hand. So initially, I will be talking about a unilateral case, when a unilateral QL imbalance is seen. If one-sided QL is overfire, the same-sided psoas, will get weak. Okay, so this is where it causes scoliosis. And if you have a client in which, if you see the ASIS of a client, and if a person has an elevated ASIS, they have a facilitated psoas, okay? And they have an inhibited QL. And if you see a client who has a PSIS and has an elevated PSIS, in this case, the QL will be overworking while the psoas will be underworking. So this I've discussed the unilateral pattern. And in case of bilateral, at the thorax, sorry, the lower angle of the thorax and the upper part of the spine, they will, ASIS and PSIS will come close, they'll have a closed jacket. As soon as we have a closed jacket, the whole thoraco-abdominal and pelvic cavity becomes one unit, There'll be very least movement available in this area. So there won't be any kind of rotations available here because it's a very closed jacket. First and foremost will be the breathing difficulty that patient will be feeling, and they will be in compensation hyper using their neck and the knee joint for the movements. So in such case, a person will be keeping the thorax and the abdominal straight, and if I'll ask that person to rotate, they will be rotating with their neck or from the knee or on the ankle, so they won't be rotating just normally, this way. I have rotated normally, and when there's a person who has a tight QL, that person will be rotating either from the knee or the ankle this way or just the neck. So they will initially come to us with neck pain also or ankle pain also. So if the QL is very tight, so they can come to us with the pain in the back also. But these clients also come to us with a lot of pain in the neck. There could be vertigo or anything, or could an ankle pain simply be there. So these are the referral patterns of the pain in which rectus, iliopsoas, multifida, and QL. These are the famous patterns which are given in the trigger point theories. Next, I will be demonstrating a few tests in which we will come to know about how all these 5 muscles can be tested clinically in any client. So I'll be asking a client to come, as soon as I just ask them to assume erect posture. Take a deep breath. Okay, leave it. And when I will be, it's a perturbation which I will be doing. I will be putting very less, like a tofu pressure on this client, and will ask this client to maintain this pressure. How much load I am putting is the amount of load I want this client to push back. Okay, breathe in, breathe out, and just match my pressure. Push me. Okay. So it's the anterior, and this client is failing this test, So now this area is working weak, hip above till this area, because this client is unable to maintain this AP perturbation. So where I will be looking for a defect in the opposite group, it's the erector group, in which we have erectors and multifida. So I will be palpating one of the points here, which will be high tone area. So I have palpated it around, this area. This is T12 and 10 area. So then again, I will be asking this client to maintain a pressure. Breathe in, breathe out. Now push again. Push. So see, instantly you see this AP test is now clear. So in this client, we have a dysfunction of abdominals to the multifida. And as usual, we see these abdominals are weak and these multifida are tight. We will be releasing those and activating the abdominals to fix this client. Okay. So now I'll be checking the posterior perturbation. I'll ask the client to again breathe in, breathe out, and match my pressure. Match. So again, this person is failing this test. Okay. Now where I will be looking for a dysfunction in the abdominals, because all these muscles have been weak to make the client be in this position. So this is the area which includes abs and the psoas. So I will be first of all palpating the abs and seeing if there is a change. Breathe in, breathe out, maintain my pressure. So yes, there was a change. Now just to show you, it could be psoas. So I am palpating the psoas. Breathe in, breathe out, maintain my pressure. So it's not. So it was the abs which were bringing the change. So again, we have a correlation like from a multifida psoas, multifida and erectors to the abs. So this is how we will be testing the AP and the PA perturbation of a person to know all these muscles. Are they weak, overactive or underactive? Now I will be showing you a simple side to side test. I will be asking this client to push me this side. This is a lateral perturbation which I will be doing. Breathe in, breathe out, push me, match my pressure. So this is a shaky test. So, okay. So I will be now, because this side QL is weak, I will be palpating the opposite side QL. So this is the point which I can find is, now push me again. So see, there's a lock. I get a lock. So again, there's an imbalance. Sorry. So there's an imbalance of right side QL and the left side QL. Water. I'll just have a sip of water. So the second case was QL to QL. So these are the 5 muscles, and how we have diagnosed, assessed these muscles. We can even do a simple test like, now I will be asking him to just forward bend, just forward bend as much as you can go. Okay, put your hand ahead. So this was his range. Okay, you could see his range. Now, as we have found out that his multifidi was overworking, I will just give a very quick release to his multifidi. Okay, now we'll be again testing his forward bending. Now go down. See, now he was able to touch the floor. So this is the way we can, with simple test of forward bending and bending backwards, we can find out. If we are unable to bend both the ways which are lesser range of motion, then it's always the diaphragm which is facilitated. If the forward bending is also affected and the backward bending is also affected, it's the diaphragm which is in the center which is affected. So in my case, both the bendings were affected. So I can give a quick release with some breathing exercises. So I gave a quick release, and now just check my range. I could go a lot back and a lot forward, So this is the case in which both the muscles, both the anterior and posterior were affected. And in that case, we are releasing the diaphragm and doing the core one. So that is all for today.
Thank you so very much, Dr. Neha, for making it kind of a practical presentation also. Thanks for your expertise, for your time, and definitely giving the insights of role of major 5 in posture. Now I would like to introduce our question and answer moderators, Dr. Elizabeth, Dr. Zafar Khan, and Dr. Pooja Sethi. They were kind enough to take my invite and be on the show with us for this webinar. So Dr. Elizabeth, my colleague, she is head of the Department of Physiotherapy, Apollo Bangalore, and she's always there in all my endeavors, and I'm grateful to her. And we have Dr. Zafar Khan, who's Dean and Head of the Department, Pacific College of Physiotherapy, under Constitute of Pacific Medical University and Pacific Medical College and Hospital. He's HOT Department of Physiotherapy, Siddhi Vinayak Hospital, Udaipur, and he's instructor of the course Essence with Attitude. Also, he is associate training faculty in many of the manual therapy and different courses like KCAT from Dr. Anamlaya, foot and shoulder rehab, cardiopulmonary rehab. Along with that, I have Dr. Pooja Sethi. She is president of Physiotherapy Forum, and she's heading Department of Physiotherapy, Dr. Ram Manohar Lohia Hospital, New Delhi. So I'm grateful to you all to be here. And she is, as I said, she's president of Physiotherapy Forum, working for professional issues for physiotherapists under Ministry of Health and Family Welfare. She's member of committee nominated by DCPTOT on scope of physiotherapy practice, ethics and standards of proficiency in physiotherapy practice. She is president, Delhi branch of Indian Association of Physiotherapists, and is instrumental in organizing many low-cost webinars in Delhi. And she's also on the panel of examiners for Delhi University, Guru Gobind Singh University, MET, and many, many more educated. So we have very eminent people who are moderators on the show. So now over to them. I believe on the chat box we have many, many questions. So people were quite keenly listening to our presenters. So over to you, people.
Thank you, ma'am. It was a very informative session. There are a lot of questions coming up in chat box. Is Dr. Marius? There is a question for you.
Yes, sure.
Is there any role for TMJ in posture and posture correction?
Well, definitely. TMJ is a very, very interesting place in relation to posture because its proximity to sphenoid bone and its proximity to suboccipitals and its relation to in between those three, TMJ, sphenoid bone, and suboccipitals regulating the position of a head, that's actually clearly works together with what's happening below our head, right? So one of our postural centers, it will be the suboccipitals and positioning of the sphenoid bone. Sphenoid bone will be trying to be as leveled as possible, right? And if for some reason the base for that, let's say neck, it's not in the most optimal position, then the sphenoid bone have to adjust. And then if the sphenoid bone adjusts, then the TMJ might not be in the best optimal position. And we might see that as TMJ disorders, but we can see that it might be related to overall posture. It's difficult maybe to explain it fully, but there is a relation between TMJ and PSISs. There was a long time ago, about 10 years ago, there was a physiotherapist in Germany, Markus Eckhart, who was kinesiotaping one side TMJ, and immediately you could see change of the positioning of the client's sacrum. It was amazing. I cannot explain that how that's happening. Please experiment yourself.
Yes.
Working with the kinesiotaping, small plaster on the one side of TMJ and look how the sacrum behaves, does it levels up. In his presentations, that was happening pretty much every single time. So there is definitely connection. There is definitely something that needs to do with all that complicated fascia around our ear and sphenoid and suboccipitals. And I can only suggest go for that book. This is 2 volumes book. Andrei Pilat, Myofascial Induction. This is 600 pages fascial book, anatomy book with beautiful pictures and descriptions and everything. This is volume 1. There is a volume 2. Altogether, this is 1,000 pages. Okay. If you know Stecco and Stecco books, this is another great book on fascia. And I think if you can get it, this is a great investment and you will have all the fascial connections really well explained anatomically. What's the precise mechanism between TMJ and that sacrum? God knows. But there is a connection. For sure, there is a connection.
Yes.
Thank you.
Thank you, sir.
So, Marius,
Yes.
one more question is for you because you are expert in that. And we know after the Anatomy Trains book came in the market, so many people having so much of question. So my question is very precise. Which anatomical line is responsible majorly for postural dissociation?
Okay. That's a difficult question. So I'll say all of them. Diplomatic answer. All of them for sure, because all of them, they are part of a postural pattern. Which one potentially have them, well, which one have the most potential to disrupt other ones? I will say will be the spiral line. Yeah, because you can see that any imbalance just at the level of a foot, and let's say any imbalance in there, in pronation and supination, both through myofascial continuities and also through the bone-to-bone relationships, it will be changing all of our biomechanics through the whole body, right? All the way to the neck, to the head. So I will say potentially it's the spiral line that has the most potential of disrupting our neutral stance, our neutral range, right? This one that will be involved in shift of the thorax, in rotations of the thorax, yeah? But on the other hand, this is the superficial line. It could be that it's the deep front line with, let's say, psoas and the multifidi and all of those deep tissues, pectineus and all of those things that are creating the pattern and holding it. So on a superficial layer, I will say spiral line as the first one to check. On a deep layer, there is always something deep, like in the onion. There is something always in the core. That would be my answer. Thank you.
Dr. Neha and Dr. Marius, thank you very much for such
Thank
a
you.
nice presentation. We are getting many questions in the chat box. My next question is for you, Dr. Neha. This Himani who is asking that how do physiotherapists assess and train the regulation of intra-articular abdominal pressure in the clinical settings for patients with posture-related conditions? So how can we actually clinically check and assess immediately? Dr. Neha.
So intra-abdominal pressure is directly related to the role of these 5 muscles, you know. As soon as we are able to assess these muscles and we are able to treat these muscles, the intra-abdominal pressure is treated, you know. And in that case, you know, I will be explaining you one thing. So while when we ask the client to breathe in, you know, breathe in and breathe out, we should see the abdominal cavity to be blowing up equally on all the parts. You know, it's not just this area which comes first and this area doesn't come. And you know, breath is felt till the last muscle, which is the piriformis. You know, piriformis even has a role in our breath. The QL has a role in our breath besides the muscle which we already know, which are the accessory muscles. Like, so we have a typical Pilates breath, which is an intra-abdominal. First of all, we fill in the air in the abdomen. It should be lateral filling up of the abdomen also. Then we breathe in through the thorax and then we breathe out. You know, in that case, the pelvic floor muscles are also the muscles which get recruited. So it works in cohesion. This whole jacket works in cohesion. We should feel the breath here also. When I'm breathing, it should be felt here, you know. And while a client is unable to do this, we ask them to bring their attention there by asking them either to put their hands there or me myself putting my hand, bring your breath here, you know, bring your attention to the breath here, you know. And if we talk about how can we work on the intra-abdominal pressure, so you all are sitting. So I just want you all to sit cross-leg in whatever seat you are sitting, you know. And there's a very good exercise which we can do. It's a part of yoga only. We'll just take this mudra, simple mudra. First of all, we'll put our hand on the knee and inhale deeply. Close your eyes. Just focus on yourself and your breath and just inhale. Just feel which area of your body is filling in air. So when we put our hand at the knee and we fill in here, it's the diaphragm which breathes in. Okay, as soon as I remove my hand here and put it on the mid-thigh position and inhale, it's the mid-thorax cavity which starts inhaling in air. And as soon as I lift my hand and put it very close to my hip joint, and that too with my closed fist, I keep it here and then inhale. It's the upper thorax which gets inhaled. So every time in all 3, we get air in different areas, and we can do this very wonderful breathing exercise any time of the day for 5 minutes to improve this intra-abdominal pressure and to improve this breathing pattern.
Thank you, Dr. Neha, for explaining it so well.
Yeah, again for Dr. Neha, they're asking, is the assessment similar to pattern in neurokinetic therapy?
See, there is nothing in specific, you know. Neurokinetic therapy has its own assessment pattern, but this assessment is related to the neurology of the body, you know. How is the neurology working, and how are these muscles working in cohesion to the pressure we are putting? You know, when we put a little pressure on any muscle, see if I'm just taking an anterior deltoid and I'm putting very light pressure, it's a neurological connection which I'm checking. It's not the strength which I'm checking. I'm just checking, is the pattern of this muscle to the brain intact? You know, even a gymmer who's been lifting 35 kgs daily with this anterior deltoid will fail this test if his neurology is affected. So for checking the neurology, which is called the activation of any muscle, we can do any muscle, you know. It could be the simple SCM, you know. We can just put a tofu pressure here and see how is the SCM working, how are the scalenes working, how are the suboccipitals working. It's just a very light pressure. We don't need to force in the pressure. When do we come to force in the pressure is when we are checking the strength. When we are checking the strength of the muscle, it's the 1 REM maximum that muscle is able to take. You know, it's the 1 repetition maximum weight a person can do with that muscle is the strength. And when we talk in the terms of endurance, you know, it's 10 repetition. It's always a set of 10 repetition with some weight is where we take the endurance, in which we make sure the 10th repetition is the most difficult or almost a client fails to perform. So that's the endurance of a person. And when we ask a client to do 3 sets, 4 sets of a thing, in that case, what will happen? That person will be recruiting some other muscle of the body. They won't be doing that particular muscle. After 10 repetitions, you will always be recruiting some other muscle. So it is always best to do any exercise. Like if you are doing abdominals, if you are doing, do a variety of exercise. 1 set each. Don't do one exercise with multiple sets. One exercise, 1 set of 10, then do the other exercise so that you can focus on different angles and different fibers for that particular muscle.
We're getting so many questions in our chat box today. So,
Yeah.
Dr. Morris, one final question for you. What is the best home takeaway tip for posture correction?
Okay, the easiest and the simplest one. Kat, you have difficult questions. So the one that's going to work for absolutely every single one, and I know it's going to work for everyone, it's keep your feet straight. Where are you going? Do not go into a lateral rotation and do not go with your feet into a medial rotation. If you will keep your, because this is your first point of failure. If you have your feet in rotation, that's already biomechanically creating disadvantage for your spine. So in any postural pattern, keeping your feet pointed where you're going, it's a good thing. So that's my advice.
Thank you.
Thank you.
And my last question to Dr. Neha ma'am. Ma'am, what is a parasympathetic theory of posture control? So please put up.
Could not hear your question.
Ma'am, my question is very simple. I just want to put a small light on parasympathetic control on posture.
I think this answer should come from you, Zafar, rather coming from me. I know because you have in-depth knowledge of this. I can only give an overview. It's you who should tell us more about this parasympathetic theory.
No, ma'am, basically you described very well, directly,
Yeah.
indirectly. Just I want to put what is
You will
all
lighten us,
behind of
Zafar,
it
in this context.
in same day, ma'am. It is now, it is already, I think it's in time. So
Yeah.
thank you, uh, Grover ma'am, to arrange such a beautiful webinar for all of us and give us a platform to share our knowledge and view about the posture. So it is a very basic thing and very important thing. And I'm very thankful to Pooja Sethi ma'am, who is so senior and available for us. And uh, the one more host is with us, Elizabeth ma'am. And thank you every participant. And now over to Pooja ma'am. So he will put in some light on that and summarize that session.
Okay, so today we had a wide discussion on posture and fascia, and I think it has given everyone a new insight, especially into structural integration and how we can, make best use of, we've always been, working on muscles, on joints, but how fascia and how important it is, and how important structural integration and our assessment is in making, and how just by assessing the patient posture, we can have a deep insight into his problems. So I think this opens a new era, and maybe, those of you who have, it has incited a new cell, and we can go for some more detailed courses and books as recommended by Dr. Marius, which would really help us learn more about structural integration. Thank you, Seema ma'am, for making me part of this, very knowledgeable webinar, and really looking forward to many more in future. Thank you, Seema ma'am. Over to Elizabeth.
Thank you. Yes, ma'am. This was a great insight for us also. Like we always connect the muscle joints and posture alignment, but we will always miss the fascia. So it was a great insight for us. Thank you all for the program today.
Over to Seema ma'am.
As always, we are overseeping the time. We keep it 7 to 8 webinar, and we are always beyond 8:30. I believe Elizabeth knows that, right? So I would like to take a moment and thank everybody. Thank all the esteemed speakers who have taken their time out of their precious time for this webinar being a weekend evening. So and to Morris, because his is the holiday. He works 6 days a week.
Thank you.
But he has
Thank
taken
you.
time out, and he's with us, answering us also so enthusiastically. Otherwise,
Yes.
finding him would be another concern. So we are really grateful to you. And this webinar, I believe, has given us, enriched us with the knowledge, right, on posture and how musculoskeletal dynamics is. We all physiotherapists are really breaking the barriers and going towards way more into the anatomy, and we have created a niche for ourselves, that how a physiotherapist can treat not only musculoskeletal, neurological, and as initially Derek put it, that yes, your emotional connect to your things, it makes it a wholesome experience, right? So along with that, I would like to express my gratitude towards current leadership of GAPIO, and especially to Professor Dr. Anupam Sibal, the Group Medical Director of Apollo Hospitals, for his constant support and vision for enabling such a platform. I believe you all will agree with me that this is a platform where many people from GAPIO, many people from physiotherapy fraternity all across the globe, they join. So this is a platform which could help us break the glass ceiling and provide superlative healthcare services to our patients. Lastly, I would like to thank all the members of the audience who are being so kind to be with us, overseeping the time. I know Saturdays are the days everybody is engaged into something or the other, and we have kept them with us. So all the members of the audience, thank you so much for making it so lively with so many questions and interactive question and answer session. And all the moderators, 3 of you have, I mean, I am grateful because whenever I request for anybody asking to moderate, and you people are available. So I'm grateful for all that also. Lastly, I would really say that yes, I would look forward that we do this session quarterly, and our endeavor is that we give the expanded scope of physiotherapy to the fraternity and globally to all the GAPIO members, so that whatever physiotherapists are doing, it is a work of its own kind. And I believe we all passionate physiotherapists are here today to be in this webinar and a part of it. So thank you, everyone. And at the same time, I would like to extend my thanks to Apollo's GAPIO team, Jitendra ji, who's here with us always, and our IT team, which helps us through to sail through very comfortably on this webinar. So to all of you, Dr. Derek, Dr. Marius, Dr. Neha, Dr. Pooja, Dr. Elizabeth, and Dr. Zafar. My special thanks to you all also, and all the member of audience. And above that, my Apollo Physio team, who are always there behind me, working at the back of the scene to make it possible. So a very, very good night to everybody. Thank you so much. Thank you so much for being with me on this. Thanks, everyone. Good night.
Thank you.
Good night.
Thank you. Thank you all.
Thank you.
Thanks.
Thank you, everyone. Thank you.